Okay, Facebook Live start يا شريف.
Guys, don't forget to mute all mics, okay?
Okay.
Recording in progress.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. We are going to talk today about antiemetic agents. So, why antiemetic agents? Why are we talking today about antiemetic agents? They are very important for us as anesthesia doctors. We are always faced with the risk of nausea and vomiting, and we know that this risk might lead to aspirations, delayed recovery, a lot of things that mean we need to decrease this risk of vomiting. So when we speak about the risk of vomiting, we are speaking about high-risk patients, and sometimes we are speaking about patients who we think that they might develop vomiting postoperatively, which is it's a common complication, and it is mainly found in pediatric patients more. So when you are speaking about this risk factor, you have to make sure that your patient is fasting well, okay, from food. You have to be sure that your patient doesn't have any risk for vomiting, such as if you are speaking about patients with laparotomies for intestinal obstruction, you are speaking about masses, you are speaking about pregnant ladies. A lot of patients come to you with this high risk for vomiting. So you always have to put in mind, you have to pre-medicate your patient very well with these antiemetics. The knowledge about these antiemetics is very important. I will speak about antiemetics in general because you have to know all of them first. Then you have to focus on which antiemetics we use before anesthesia, during anesthesia, and even post-operative anesthesia. So that will be the end of the session discussion of which antiemetic we are going to choose for our patient every time we are going for general surgery. So this diagram is speaking about the general concepts, physiological pathway of vomiting and how does vomiting occur. It is mainly having three important centers in the brain, and we have a peripheral centers in the gut, impulses coming from the gut. So the three main parts that are involved in vomiting is the cortex, and we have the vomiting center, we have the chemoreceptor trigger zone, and we have the vestibule or the vestibular nuclei. All these centers are found centrally, and I'm going to speak about each of them in very small words so you can understand the involvement of these parts in the vomiting center, or in the vomiting generally. We have the GIT, as we can see here. We know that most of the GIT symptoms can lead to vomiting, so it has some involvement in the trigger of vomiting. Okay, this diagram, I found it's much more clear than the first one. As you can see, we have, this is the brainstem, we have the medulla, and we have the pons above the medulla. In the medulla, we have the vomiting center, which is the main center for triggering vomiting, and it has the main receptors we find here are the muscarinic receptors. So this center is having it has so many impulses coming from everywhere. يعني انت عندك impulses coming from the high centers, from the brain, from the high centers, from the ears, as I said before, and even from the chemoreceptor trigger zone. I'll start by the chemoreceptor trigger zone. This center, or this group of nuclei, are mainly found in the medulla oblongata, and trickily it is found outside the blood-brain barrier. It is very sensitive to the things that we give intravenously, whether drugs, even sometimes when you are giving the antibiotics during anesthesia, لما تيجي تعمل induction anesthesia يقول لك the surgeon give this patient the antibiotic, okay? You don't see this reflex. Like if you are giving it for an awake patient, sometimes if you speed up the dose of the antibiotic, the patient will feel anxious, so or nauseous. So this nausea is triggered by this chemoreceptor trigger zone. It is found outside the blood-brain barrier, and it is very sensitive to the whatever drugs and toxins you are giving intravenously, including the chemotherapy that you give for cancer patients. So when I see a patient who is starting to be nauseous, while am I giving this drug, whatever the drug is, you have to think that this nausea is triggered by the chemoreceptor trigger zone, which is this one. And you can see the number of receptors that are involved in this center. You have serotonin, you have dopamine, you have neurokinins, and you have enkephalins, or all these receptors. طبعا neurokinins and enkephalins, there are newly discovered. Even the drugs that are in the market now for these two receptors, or these two types of receptors, are considered as new drugs. The old ones that we know, اللي هي عندنا serotonin and the dopamine, they are both found in the chemoreceptor trigger zone. So always remember that when you are giving drugs, this is the thing that you are influencing the vomiting with. طيب نجي the other part that is involved is the ears. We have a vestibule in the ears, here hairline and the fluid line inside the ear that keeps the balance of the body. When you are going on an airplane, or sometimes if you are, some people, they are much more sensitive, even if they are in the back seat while you're driving a car, or even in the sea. خلاص دي كلها areas that بيحصل disturbance in this membrane, in this fluid line, and it will trigger impulses. The movement of these hair cells will trigger impulses that goes to the vestibular nuclei, and this vestibular nuclei will stimulate the chemoreceptor trigger zone. Okay, stimulate the vomiting center, then it will stimulate the vomiting reflex. طيب, in this vestibular nuclei, we have H1 receptors, اللي هي histamine receptor type 1, and we have muscarinic receptors. Why do we need to know the receptors for each centers? Because the drugs that we are going to talk about, they act on these receptors, and they will inhibit the vomiting reflex. Sometimes you might use combinations. If you have very severe vomiting, you can use combinations, but if you are using combinations, you have to know that using different receptors, different sites will much more affect will be much more effective than using a single group of drug that works in just a single receptors. So you can use different types of drugs on different receptors, that just like
ايوه لانه هي عارفه اشكالهم كيف.
يا جماعه بليز لما تدخلوا اعملوا ميوت للمايكس بليز. تمام. So knowing these receptors, you will know which drug you are going to choose. And if you are going to add a drug, you have to know that I'm adding this drug because it's working in another receptor that will inhibit vomiting. Just like a multimodal thing. Okay, so this is the other path by the vestibular nuclei, chemoreceptor trigger zone, then the vomiting center. We have another path here from the high centers of the brain, or the high brain centers. These centers, they have many emotional and many psychological changes like anxiety. It has a lot of centers that have impulses from the nose, from the ears, from the eyes, from the ears. And these are things that might trigger nausea in some patients, like people who cannot stand looking at blood. If they see blood, they start being nauseated. مثلا bad smells. If you have some, you came with a very bad smell and you start vomiting. All these triggers, sensory triggers, come from these high centers directly to the vomiting center, and they trigger vomiting. So these 3 or 4 centers are involved directly or indirectly in the vomiting reflex. طيب نجي للperipheral part اللي هو عندنا the stomach. Okay, and the stomach, we have cells in the stomach, and in the stomach we have serotonin اللي هي برضه 5-HT receptors. When these receptors are stimulated by irritant things, by stretch, mechanical, sometimes if you have obstruction of the flow, stretching, whatever mechanical, or even the compounds of the fluid, the food, if it was very irritant to the mucosa, these will trigger impulses via the vagal nerve directly to the vomiting center, and this is going to trigger the vomiting reflex. So all of these things are involved in stimulating this vomiting center. After stimulation of the vomiting center, containing mainly muscarinic receptors as we agreed on, بيحصل حاجة اسمها vomiting reflex. What is the vomiting reflex? What is going to happen if you are going to vomit? First of all, we have a bit stimulation for the sympathetic. There will be tachycardia, a bit sweating, a bit anxiety, and these are physiological changes you might have a bit increase in the blood pressure. And the thing that is going to happen in the gut, that is the lower esophageal sphincter is going to open, common sense, because we need to get all the things that in the stomach or the upper part of the bowel outside. So the lower esophageal sphincter is going to open, and the food expulsion is going to be directed upwards. So what are the things that is going to help in the food going out in this forceful way? We have the contraction of the diaphragm. This is the first thing. And we have contraction of the whole abdominal muscle. This is going to increase the intra-abdominal pressure. And you can think about that, the much more force that is going to happen, the much more expulsion it's going to be, expulsion of the food is going to appear. And here بيحصل لنا الfood going to go outside the mouth. تمام؟ معناها أنا لما أتكلم عن vomiting أنا بتكلم عن involvement of different neurocenters بتكلم عن involvement of the GIT، بتكلم عن vomiting reflex، بتكلم عن contraction of the diaphragm، upper esophageal sphincter open, and increasing the intra-abdominal pressure by increasing the contraction of the abdominal wall. كده احنا we spoke about the basics of vomiting. How does vomiting occur? تمام. طيب. Let us go for the next slide. I summarized all these things. We have the vomiting center in the medulla, composed of muscarinic receptors. Stimulation leads to vomiting reflex. In a chemoreceptor trigger zone located in the medulla, but this one is outside the blood-brain barrier. You always have to remember this. All the other centers are within the central nervous system, but the chemoreceptor trigger zone is outside. طيب, has dopamine, serotonin receptors, opioid receptors, you have to know that, cannabinoids, activated by drugs like different drugs, عندنا glycosides, morphines, عندنا kinin, you know, a lot of drugs that can stimulate this chemoreceptor trigger zone. It stimulates vasoconstriction and increase in the blood pressure. The vomiting center, vomiting center. طيب, عندنا vestibular system. It is important in motion sickness, you know that. It stimulates the vestibule. The vestibule will go into stimulate عندنا vestibular nuclei, and this will go into stimulate the chemoreceptor trigger zone, then followed by the vomiting center. It has muscarinic and histaminic receptors, and these are going to be involved on antiemetic agents حقت إن شاء الله. طيب, عندنا high centers, psychiatric disorders, stress, smell, emotional. These stimuli can trigger the vomiting center. طيب, GIT عندنا vagal, enteric, afferent mucosa of the GIT are rich of serotonin اللي هي 5-HT receptors, and it is stimulated by irritation of the GIT, sometimes by mechanical stimulation. What is induced vomiting? You know that induced vomiting? Sometimes we have it in patients with anorexia nervosa. These patients, they always present with, they just put their mouth inside the throat. When you put your mouth inside the throat, you stimulate the vagus nerve. It's as simple as that. Stimulating this vagus nerve will give impulses to the vomiting center and will cause the vomiting reflex. طيب. طيب, sorry. We're going to talk now about drugs. The drugs that are used as antiemetic agents, عندنا منها dopamine antagonist. طبعا we use a lot of them في السودان هنا. We mainly use metoclopramide and the domperidone. The metoclopramide and the domperidone number 3. These are most commonly used in Sudan, inside the hospital and outside the hospital, both of them. The most important things that you have to know about them is blocking the dopamine. You know that the dopamine and the acetylcholine are found inside the brain in a balance. And this balance has effect on the behavior, has effect on the movement of the patient, the balance movement and everything. So these drugs, the problem of these drugs, they inhibit the dopamine receptors in the brain. And here mainly D2 receptors. And these D2 receptors with a long time, إذا أنا عملت inhibition للدوبامين receptor, I will cause a Parkinson-like symptom. يعني لو إحنا متذكرين الباركنسون disease, كويس. In Parkinson disease, there is a drop in the dopamine level in the brain, and there is an increase in the acetylcholine, and this acetylcholine causing the abnormalities in the movement and so on, so on, so. Okay, so when I'm speaking about dopamine antagonist, you always have to think about that balance. If you exceed the block for a long time, this block has been sustained for a long time, you might cause a Parkinson-like effect. You have to always think about that. And this Parkinson-like, it is symptoms, they are called extrapyramidal symptoms. You have to think always about them, especially when using the metoclopramide or the domperidone, because these are now used daily sometimes for patients. If you have a complaint, you have to, you might treat the symptoms now, but you have to seek what is the underlying cause and you have to treat that. So these drugs, here dopamine receptor drugs or dopamine antagonist drugs, these drugs, they mainly found in a group of antipsychotic agents like like the phenothiazines. here عندنا الكلوربروميدين, this is an antipsychotic agent. The most important thing about phenothiazine, you always have to remember about the chlorpromazine, it has an alpha blocking effect, by the way. I didn't write that. It has a muscarinic effect and it has an antihistaminic effect. All of these things are can present as side effects plus the antiemetic effect. They have a very good benefit on behavioral control in patients with schizophrenia, but still all these receptor blocking thing might lead to a lot of side effects. One of them is, if you are thinking about dopamine block P2, you are speaking about extrapyramidal symptoms, muscarinic receptors, you have dryness, you have some tachycardias, and so antihistaminic effect, sedative effect, sometimes dizziness and drowsiness, and the alpha blocking effect sometimes cause hypertension. All these side effects are caused because of the multi-receptor blocking effect of the phenothiazines. عندنا البيتروفينونز اللي هي droperidol. This is also one of the antipsychotic agents and or antipsychotic agents, yes, and it causes extreme sedation with still extrapyramidal side effects. And metoclopramide and the domperidone, they are still having the same dopaminergic blocking effect, لكن عندهم effect ثاني directly on the stomach. It causes increase اللي هو gastric outlet flow. معناها it aids to flow gastric content downwards, not upwards. ودي من ال very nice effects بالنسبة للميتوكلوربراميد. لكن إذا أنا بتكلم عن intestinal obstruction patient ولا بتكلم عن patients with atresia or with mass or with إن شاء الله حتى لو partial obstruction, all these patients using metoclopramide is not advisable because you are speaking about increasing motility against an obstructed area. So it's not a wise thing to use them. It might cause more abdominal pain in these patients, but think about using other types of antiemetics other than metoclopramide and domperidone. Lately, some papers came out about domperidone causing cardiac problems, and بالذات if you are chronically using them, but this is still under investigation, and still domperidone, it is a very good drug. طيب. Serotonin antagonists, these are the magical antiemetic agents, and we always اللي هي عندنا سيروتونين، عندنا الأوري، the citron family. في زول شغال في الشاشة يا شريف. طيب the citron family اللي هي عندنا ondansetron, gansetron, whatever citron you find. صوتي واضح؟
Yes, very clear.
Okay, so we have the citron family اللي هي عندنا serotonin اللي هم 5-HT3 mainly antagonist. These are drugs that work mainly on the chemoreceptor trigger zone, and it also works in the stomach في ال GIT cells اللي هي reflex from the stomach. So these 5-HT receptors, they work in two places. They are very effective. The choice of these drugs بيبقى في إنه how long do you want the antiemetic effect? Is it just for the surgery or you need it post-operatively? For example, in sleeve gastrectomies, sometimes you need the antiemetic effect for months and months, a long time. So you might think of ganacitron or granicitron as it works for more than 24 hours, very long-acting agents, more than the ondansetron. It has a lot of different names. It has a lot of variety of drugs, the citron family, and we have ondansetron هنا في السودان وعندنا granicitron بس ما commonly used لكن it is there and it is a very long-acting agent for once per day use and very effective. Anticholinergic طبعا احنا من قبل بنتكلم عن انه the involvement of the muscarinic receptors in the vomiting center and in the vestibular center. So these two centers, if you block the muscarinic receptor, you might cause relief from vomiting. Putting in mind the anti-muscarinic effect might have a lot of side effects, and we're going to talk about that. عندنا الانتيهستامينز خلاص اللي هي H1 receptors، والانتيهستامينز من اللي قلنا برضه موجوده في الفيستيبولار نيوكلياي فيها الهستامين H1 receptors. عندنا الدايهيدرامين or hydramine، وعندنا cyclazine. This is the much more common one, the cyclazine. Everyone have cyclazine, especially motion sickness patients. They take this drug as pre-medication before going sailing or before going by airplane. It is very effective as an anti-motion sickness drug. عندنا في البروميسازين وده برضه بالمناسبة من it is an antihistamine and it has a muscarinic effect, and it is used for as an antiemetic effect, but it has a lot of other effects. It has a sedative effect, and it is used in pregnant ladies during deliveries, especially if the patient was in severe abdominal pain, and during delivery it is very effective, by the way, as pre-medication in the first stage of labor. عندنا vitamin B6. It is طبعا الرول الميكانيزم it's not clear لكن it has an antiemetic effect. It's not that strong antiemetic effect لأنه still you have some pregnant ladies, they come with vomiting while using vitamin B6, but you can add ondansetron to the antiemetic drugs for these patients, putting in mind that by guidelines it must not be given in the first trimester. It can begin for the second or the third trimester, but first trimester is still not allowed to use it. طيب عندنا النابلون, and this is synthetic cannabinoids and with a very potent antiemetic effect. طبعا cannabinoids it has a very strong antiemetic effect. Put in mind that sometimes we have drugs that act also on opioid receptors, but these drugs will stimulate vomiting center like morphine and pethidine. These all drugs can cause vomiting, and cannabinoid is one of the very potent antiemetic agents. طيب Therapeutic uses. Common sense, you are going to use them in motion sickness. تمام. As a prophylactic. لو أنا جيت أختار للmotion sickness هختار مثلا cyclazine as an antihistamine. هختار هيوسين هيقلل لي الابدومينال بين والكرامبس والحاجات دي، في نفس الوقت هيديني اللي هو it will يعني decrease the problem it will decrease the vomit and nausea and it will decrease the vomiting of pregnancy. عندنا برضو antihistamines B6 sometimes ondansetrons or acetotrons can be used as I said but not in early pregnancy. عندنا vomiting due to diseases, due to drugs, due to radiation, post anesthesia. كلها دي احنا ممكن نستخدم antihistamine, cyclazines، ممكن نستخدم metoclopramide، ممكن نستخدم domperidone، ممكن نستخدم الفينوسايزين، الكلوربرومازين، ممكن نستخدم الاوندانسيترون، ال 5-HT antagonist. دي كلها احنا ممكن كل الدراجز اللي احنا قلناها قبل شويه can be used as post-operative nausea and vomiting, can be used for chemotherapy, radiotherapy patients with safety, because you are going just to use them once or twice and that's it. But if you are going to use them for a long time, you have to bear in mind the side effects of these drugs. Vomiting due to cytotoxic drugs, عندنا metoclopramide, domperidone, nabilone, 5-HT antagonist, receptors اللي هي كل الاوندانسيترونز. These all drugs can be used for vomiting. طيب side effects. طيب antihistamines, you know that they induce sleep, though we have new modalities of antihistamine agents, but we are speaking about 5-HT1 antagonist. Most of them, they cause sleepiness, dry mouth, dry nose, and you will feel the dryness while, because it's like a decongestant effect. So it will dry all the nose and the throat and the airway. Cannabinoids and alter the state of perception, dizziness, they can cause a bit dizziness. Dopamine receptors, you know that they cause irritability, constipation, some tinnitus in the ears, dry nose or dry mouth, and restlessness, and then a muscle spasm. Once you develop the muscle spasm, the tremors, you know that these are signs of the extrapyramidal symptoms. So a lot of people use these dopamine receptor blocks for a long time without realizing that they had suddenly developed tremors and restlessness, and sometimes the gait, when they are walking, their gait has been changed, and you have to be very careful in assessing on clinical assessment of these patients. Serotonin receptor blockers عندنا mainly they cause headache أكتر حاجة. بعد كده عندنا fatigue, dry mouth, constipation. عندنا bismuth subsalicylates. I found these drugs, by the way, they act locally in the stomach, and the problem is they cause blackish stool, changes in the tongue color, but still it acts locally in the stomach as it decreases the irritation and it can settle vomiting or the nausea, but still it has side effects like the blackish stool and the tinge color on the tongue from the drug. عندنا steroids، عندنا مثلا تعمل لنا indigestion، increase appetite. If you're going to use them for a long time, you might expect acne, you might expect trunk obesities, changes, moon face, you know, all the side effects that can be expected from steroid use. A lot of researches indicated that dexamethasone has an antiemetic effect. So now it is like a routine. Every one of us use premedication with dexamethasone with the induction of anesthesia. It is found to be very useful actually. And I haven't been faced by postoperative nausea or vomiting for a long time, other than the patients that already had coming with a bowel surgery or مثلا resection anastomosis and they have already a bowel problem. Other than that, I haven't been faced by nausea and vomiting since I started using dexamethasone preoperative or during induction of anesthesia. Okay, I think that's all, and I just need to emphasize some things about the mechanical induction of vomiting, real gagging, and these are the one thing that faces an anesthetist while doing awake intubation for patients with awake fiber optic intubation or awake direct laryngoscopy, examination of the airway, and you can block that reflex by nebulizing a lot of local anesthetic or gargling of local anesthetic can help to decrease that reflex and decrease stimulation of the vagus nerve. This is very important. You have to know that. And you need also to pre-medicate with a muscarinic blocker to add the effect of blocking the muscarinic receptors. Very important. You need to also pre-medicate with additive antiemetics if possible, like ondansetron. You can add hyoscine or sometimes pre-medicate with atropine. All these drugs together will aid fiber optic intubation without making the patient uncomfortable. And you just have to, don't forget the gargling or the nebulized local anesthetic. This is one of the uses of antiemetic agents. Also, we have a lot of protocols of talking about giving pre-medication of antiemetic agents for patients with high risk of postoperative nausea and vomiting, like patients with esophageal surgeries, with gastric surgeries, sleeves, and bypass surgery. All these surgeries are patients will be very high risk of postoperative nausea and vomiting, and they will be very uncomfortable postoperatively. We also start pre-medicating these patients with a very high dose of ondansetron, 16 milligrams, and you can use them. You can use them for pre-operatively and post-operatively for the following days. Put in mind that metoclopramide might make things worse for this patient because it is a prokinetic, it is an antiemetic agent, but still it's a prokinetic. It will aid the motility of the gutter. So you don't need that in these patients. I think that's it. Any questions? It's a very small session today. Sharif?
Any question?
From Facebook, no question till now.
Okay, we need to thank Rahul Choube from Live Anaesthesia TV, which is our new collaborated platform.
We thank them very much for this opportunity, and we hope that inshallah we have a lot of collaboration with them in our teaching sessions. We have a academic schedule for at least another 2 or 3 months, inshallah, and we expect collaboration of a lot of consultants and residents in the next coming weeks. Inshallah, this is a very good beginning, and I think spreading this knowledge to everyone, it is a very important thing, you know, and all of us to share this information. And we are also appreciating that if they have any academic activities coming through their societies or boards, we are also happy to know about them and to attend these sessions, inshallah. Oh, excellent. Okay, thank you very much. Thank you.
Recording stopped.
طيب
Any questions? Okay. طيب we expect إن شاء الله يا شباب next week هتتكلم معانا دكتورة هالة عن fluid management in major surgery.